fluids that fail to proceed through an orderly, timely process to produce anatomic and functional integrity. Commonly, we can see it through formation of ulcer, like venous ulcer, cavity ulcer, ischemic wound, and also pressure ulcer. And the last one would be non-healing wound, which is a wound that has no sign of healing process within 2 to 4 weeks of the appropriate intervention. And this wound have a different kind of etiologies, each one of them. Some can be traumatic, some can be sacral sore, vasculitis, burn, surgical wound, and other types of etiologies. And next. So in formation of wound healing is basically a mechanism whereby the body attempts to restore the loss of skin integrity of the injured part. It composed of a complex process of wound healing process which overlap towards each other, and it is initiated by an injury of the wound, and it involves two distinct processes, which is regeneration and also repair. For For regeneration is a proliferation of the parenchymal cells and tissue to replace uh, the lost structure. The damaged cell are also able to return to its normal state by proliferation of cells or maturation of the stem cells and deposition of the connective tissue. And regeneration depends on several situation where mostly due to regenerative capacity of the involved cell. It also depends on the number of the surviving viable cells. It also depends on the presence of connective tissue framework that provide base uh, the base for restoration of normal tissue structure, as we can see through the two epidermis and also the base layer, which provides extensive vascularity for the formation of wound healing. And the second one is repair with proliferation of connective tissue element, which results in collagen deposition that gives structural stability and also fibrosis, which can lead to the formation of scar. It occurs when there's a resolution fail to occur on an acute inflammatory process. There's still an ongoing tissue necrosis in chronic inflammation, and the parenchymal cells necrosis cannot be repaired by regeneration. And next. So these phases of wound healing, it composed of four: hemostasis and also coagulation. The second one, inflammation. The third one, proliferation and migration, and the last one would be remodeling. Next. So basically, in hemostasis, there is a process of bleeding spontaneously, which stops and maintains the blood in the fluid state. There will be vasoconstriction and also thrombus formation, which can limit the blood loss. There will be platelet aggregation, which later on can trigger the coagulation pathway, which result in fibrin matrix, which stabilize the wound. And there will be fibrin clot, which serves as a scaffolding for the migrating cell. The second part is inflammatory phases, which can occur day 1 to day 3 of the formation of the wound. Following it involves the platelet degranulate to release cytokine, the platelet-derived growth factor, TGF beta, and also platelet factor 4, which would lead to attraction of the inflammatory cells. And this would lead to increased vascular permeability mediated by histamine, nitric oxide, serotonin, which produced by platelets and also endothelial cells. And this coordination of the inflammatory and growth factor response by neutrophil, macrophage, and lymphocyte will lead to the formation of the inflammation punya features, which is the redness, swelling, heat, and also the pain. And the third part is the proliferative phase, which can occur from day 2 or day 3, and even until 3rd weeks. In this phase, there will be granulation tissue formation. Uh, there will be fibroblast proliferation, which collagen synthesis with rapid gain in tensile strength, which is composed of type 3 collagen. And there will be angiogenesis, formation of new capillaries from endothelial cells. There will be wound contraction and also reepithelialization, which involves the proliferation and migration of the keratinocytes adjacent to the wounds. And the last one will be maturation and remodeling phase, which can occur in week 3 and last to a month or years. In this phase, the maturation of collagen type 1 will replace the type 3, and there will be reorganization of collagen fibers along the lines of tension. There will be organization of the scar, decreased wound vascularity, and the gradual gain in tensile strength up to 80% of the normal usual skin integrity will be restored. And next, so in formation of wound healing, there will be different types of wound healing, which is primary, secondary, and also tertiary, or also known as delayed primary intention. So in primary wound healing, there will be the wound edges still opposed with minimal granulation, minimal scar. Regeneration is more than scarring, and this will lead to this due mostly in most cases will involve due to a clean surgical ataupun traumatic scar. The secondary intention is the wound left open, which heals by granulation, contraction, and also epithelialization with increased inflammation and proliferation, and also poor scar formation. And in this secondary intention, the scarring is form more rather than regeneration. And the last one is tertiary intention, also known as delayed primary intention, commonly due to involves in cases of contaminated or untidy wound, and the wound left initially left open for several days for irrigation or debris removal, as we can see in the operation for knee washout ke, tentu the wound left open for irrigation for several days. And the ages later oppose when healing conditions favorable, and as a result, there will be a less satisfactory scar. And yes, and all of this process, the wound healing, wound formation, the intervention, there are many factors that could affect it. And it can be divided into local and also systemic. Local tissue oxygenation, prolonged hypoxia can cause tissue damage. Infection, prolonged inflammation can cause wound to enter into a chronic state and fail to heal. Foreign body can cause prolonged inflammatory response and increased risk of infection. Vascular insufficiency cause poor circulation affects the supply of oxygen. Advanced age can alter because increase of age alter the inflammatory response, delayed rehabilitation, and all of the physiological response. Obesity can cause increased tension on wound edges, which result in wound adhesion, and it also cause associated with pressure-related injuries. And skin folds harbor more microorganism rather than non-obese person. Stress also, psychological stress can regulate pituitary and also adrenal hormones, which can cause impairs the normal cell-mediated immunity. Malnutrition, lack of protein, lack of vitamin C can could affect the wound healing process. Um, Associated disease like diabetic foot ulcer in diabetic patient can affect the wound healing itself, can cause prolonged wound healing and also impact the intervention that we want to give. Indication like glucocorticosteroid and also NSAID will lead to a reduced inflammatory response as they inhibit the inflammation itself, which is vital for the wound healing. Smoking, nicotine will interfere the oxygen supply, stimulate sympathetic activity, and also increase in blood viscosity. Plus, carbon monoxide and also hydrogen cyanide which involves the association with tissue hypoxia. Immunodeficiency, like chemotherapy patient, will lead to inhibit the inflammatory response, reduce the inflammatory cell, and this would impact the wound healing process. And the last one would be genetic disorder, likely connective tissue disorder such as Marfan syndrome. The, yeah, I think that's all.
Okay, so Assalamualaikum. My name is Atira. So I will proceed with wound assessment. So like other examination. So in wound itself also have general assessment and also local assessment. So for general, we to identify and eliminate any underlying causes or any contributing factors that can impede the wound healing process, like age, disease or comorbid, any medication like steroids, anticoagulants, or any chemotherapy previously, obesity, poor nutrition and hydration, those who are like impaired blood supply, and also the lifestyle smoking, like smoking. While for the local assessment, so first we need to take a history, like how the causes of the wound, the site of the wound, and also the onset of the wound. And for the physical wound characteristic, so first we need to location and the size, like in the picture on the right. So for the size, we can measure the wound surface area, like length, width and depth. And also for the surrounding skin, so we look for any sign of infection, ischemia, or any maceration like soggy skin surrounding the skin. And also next is a pain. Is it the wound pain as well as the wound bed condition? Wound bed condition has a mnemonic time, TIME, that will be explained later. So next, okay, so for the site of the wound, so site itself can give a clue the causes of the type of the wound. Like for example, the venous ulcer, the common is at the greater area of the leg, pressure ulcer at the sacrum, greater trochanter and heel. While for the arterial or vascularity ulcer, maybe at the dorsum of the foot, and diabetic more common at the plantar and lateral aspect of the foot and toes. Or for the lateral malus also can be either venous, arterial, or pressure ulcer. Okay, so like I mentioned before, the wound bed assessment is that have mnemonics of TIME, time, is a systematic approach to evaluate and remove the barrier to the healing process to allow the wound healing to progress normally. So this TIME, it guides the appropriate treatment strategies that can target both patient in general and also to treat the underlying disease that caused the wound itself. So for the time, T is a tissue management, I, inflammation and infection control, M, moisture balance, E is a epithelial or age advancement of the wound. Okay, so we go for T, tissue. So it represents the tissue type in the wound. So we can look at the tissue by using a color, either viable or non-viable. So for the color, epithelial tissue is more likely to be pink, like pink and also pearly white and wrinkles when touched. So this and also granulating tissue is also a viable tissue, more appears like red and moist. And this granulating tissue form when in the remodeling phase, which is this phase is well vascularized and easy to bleed. While for the non-viable, we have slough and also necrotic. So slough more to yellow or brownish in color, and necrotic tissue appear hard, dry, and black. So this necrotic tissue will prevent the wound healing. So both slough and necrotic usually we debride. So how to identify the non-viable of the tissue? By looking at the color, like the dark color, consistency like mushy or soft, contraction, fail to contract, and also circulation means absence of bleed. Okay, so these are the type of tissue that I mentioned, like this is the granulation tissue, necrotic, and also the slough tissue. Okay, so for eye, so inflammation is a part of wound healing, but when there is an infection, it can impede the wound healing. So we need to examine any local or systemic symptoms like local pain, erythema, edema, warm, increased exudate or pus discharge, and also foul smelling. While for the systemic, patient usually fever, general malaise, and also lymphangitis, and also increase in white blood cell. So M is a moisture imbalance. So moisture is essential for healing process to promote epithelialization, provide nutrients, and also maintain the moisture of environment. But if there is excess exudate, it can lead to maceration and also degradation of the skin. While too exudate, too little of exudate, the wound bed will be dry. So we have like serous, fibrinous, purulent, hemopurulent, and hemorrhagic exudate. So for the age of the wound, so during healing, usually the age of the wound, the epithelial cell will migrate across the wound bag to cover the surface of the wound. So to allow this migration, the wound edge need to be moist, intact, and attached to the base of the wound. But if the epidermal margin fail to migrate, or the wound edges fail to contract and reduce in size, we need to review back if there is any problem in the tissue, if there's any infection or moisture imbalance. So the common can be undermining, roll edge, or dehydration. Okay, so the last one will be documentation. So we need to document all the assessment, treatment, also management plan clearly and comprehensively. So because we can evaluate and planning of the wound management in future, as well as to monitor the wound progress and also for communication tool. So I think that's all from me.
Okay, so my name is Nushafika binti Watia, and I will be continuing about the wound bed preparation and also debridement. So next. So basically, the definition of wound bed preparation is the management of a wound in order to accelerate endogenous healing or to facilitate the effectiveness of other therapeutic measures. So the table on the right side is the summary for the wound bed preparation and also debridement. So next. So as mentioned before, that the wound bed preparation and debridement is categorized into four, which is according to the TIME mnemonics, which is the first one is tissue management, I for the infection or inflammation management, M for moisture imbalance management, and also the last one E for age of wound management. So first we proceed with the T, which is tissue management. So basically, in tissue management, there's a wound debridement, where wound debridement is a process of removing devitalized tissue and or foreign materials to promote healing process. So the methods that may be used in tissue management in wound debridement is either surgical debridement, autolytic debridement, enzymatic debridement, mechanical debridement, biological, and hydrostatic debridement. So next. So moving on to the first one, which is surgical debridement. The indication for surgical debridement is include extensive devitalized tissue, signs of advancing soft tissue infection or sepsis, presence of thick adherent scar, and also callus formation. And the methods for the surgical debridement using sharp tools, including scalpels, scissors, curette, Humvee knife, and also electrical dermatom. Okay, so next. So basically, the basic principles for wound debridement is the first one is we debride in stages where we minimize the damage to healthy tissues, and the second one is staying within a given fascia plane to avoid spreading bacteria to a lower layers, and the third one is small bleeders can be stopped with the application of pressure, while the large bleeders require diathermy or ligation of vessels, and the fourth one is the pain control during the debridement. It can be achieved using oral analgesics, topical analgesics, intravenous or intramuscular drugs, and also regional or general anesthesia. So next. So basically, this table describes and compare between the intraoperative operation of the tissue differentiation between the non-viable and viable tissue. And as we can see, there's a differentiation between viable and non-viable tissue of the fat, fascia, muscle, and also the other tissues. Okay, so next. Okay, moving on to the second point, which is autolytic debridement. So basically, the definition of autolytic debridement is it is a process by which the wound bed utilizes phagocytes and proteolytic enzymes to remove non-viable tissues. And this process can be promoted and enhanced by maintaining a moist wound environment. So the mode of action, we commonly we use hydrogel, where it will gently hydrate the dry necrotic tissues and it provides moist wound healing environment and soften the necrotic tissues. Next. So the third method is enzymatic debridement. So basically, they use topically applied enzymatic agents to stimulate the breakdown of the non-viable tissues. And according to the name, it's enzymatic, meaning that it is faster compared to the autolytics, meaning that we give something to facilitate the process. And example of the enzymatic agents are Clostridium peptidase A, honey, and fibrinogen with DNase. Next. So next methods is through mechanical debridement, where the first one is wet to dry gauze, where there is a usage of gauze to peel the necrotic tissue from the wound bed, and this procedure can be painful. And the next one is scrubbing, where we use the blunt edge of the scalpel or forceps to remove the biofilm and debris. And the third one is whirlpool, where this utilize low pressure water force to cleanse and debride the wound bed, and this is less harmful to the normal cells. And the last one is the wound irrigation, where it use a non-antiseptic cleansing solution to irrigate and debride the wound. Next. Okay, so the next method is through biological debridement, where one of the modality is using the maggot debridement therapy, where they use the sterile maggots for the debridement of wounds in humans. And the maggot species that commonly used is Lucilia cuprina and also Lucilia sericata. So basically, the mechanism of action for biological debridement include removal of the slough, where there's a protease dissolve the necrotic and infective materials, and it stimulates wound healing, where it promotes granulation and epithelialization. And the last one is through disinfecting the wound, where it ingests the bacteria, alter the pH, and also it have antibacterial substances. Next. And the last method is through hydrostatic debridement, where it uses high power hydrostatic debrider, which is a powered instrument for surgical debridement of wounds. So basically, it excises tissue with a stream of saline, and it combines localized vacuum removing excess tissue immediately. This is the high power hydrostatic debrider that can be used in hydrostatic debridement. And also in hydrostatic debridement, it enables the surgeons to precisely target and remove the devitalized tissue and contaminants, and at the same time preserve the collaterally healthy tissue. So next. So next, moving on to the infection or inflammation management. Basically, the management of infection and inflammation aim to improve the host resistance. So among the methods that can be done to improve the host resistance include promote healthy healing, healthy eating, encourage smoking cessation, and also address underlying medical condition to promote the wound healing. And then the local methods include the debridement to remove the devitalized tissue, wound cleansing, and also topical antimicrobials. And also the usage of systemic antibiotics are only applicable if there is evidence of deep infection or where the infection cannot be managed with local therapy. So next. So next is the moisture management, where whereas we know that both excessive or inadequate exudate production may affect healing, meaning that the moisture status of the wound cannot be too dry and cannot be too moisturized. And appropriate wound moisture is required for growth factors, cytokines, and also cell migrations. And if there's a too little exudates, it can inhibit cellular activities and leads to eschar formation, which will inhibit the wound healing. And also too much exudate can damage the surrounding skin. So among the methods, next. So among the methods for the moisture management is negative pressure wound therapy, where it provides a close and moist wound healing environment, and it decreases the wound volume. It also removes excess fluid that can inhibit wound healing. It helps to remove interstitial fluid and also promotes granulation. Okay, next. So basically, the indication for negative pressure wound therapy includes a huge clean and or exudative wound while waiting for definitive wound closure, or fixation of skin graft and tissue flaps. And among the contraindications are clotting, where the patient having clotting disorder, there's a necrotic wound bed or ISTA, untreated infection, neoplastic tissue in the wound area. And the complication for negative pressure wound therapy is toxic shock syndrome, wound infection, blood and fluid loss, and the side effects include ingrowth of granulation tissue into the foam, pain, maceration and pressure damage, and also reduction in perfusion. So next. Next is the last one, which is the age management, where among the methods that can be used is hyperbaric oxygen therapy, electromagnetic therapy, laser therapy, ultrasound therapy, and also NPWT as mentioned before. And the most common type that we use is the hyperbaric oxygen therapy. So next. So let's talk a bit about hyperbaric oxygen therapy. So basically, it intermittently breathing pure 100% oxygen at greater than ambient oxygen. And it uses oxygen as a drug and hyperbaric chamber as a dosing device. And this will elevate the tissue oxygen tension. So, hyperbaric oxygen therapy can be used as adjunct therapy in diabetic foot ulcer, osteoradionecrosis of mandibles, and others indication that listed. And the mechanism of action of the hyperbaric oxygen therapy is through angiogenesis, bacteriostatic, and bactericidal. It inhibits Clostridium perfringens alpha toxin synthesis. It also causes vasoconstriction, enhanced collagen synthesis, and also leukocyte oxidative killing. Next. So, for the contraindication for hyperbaric oxygen therapy, there is an absolute and also relative contraindication. So, for absolute contraindication, where the patient have untreated pneumothorax or the patient on medications such as bleomycin, cisplatin, disulfiram, doxorubicin, and also sulfamylene. And among the relative contraindication includes asthma, claustrophobia, COPD, and so on. So, I think that's all for my part.
Assalamualaikum, I'm Akila, and me and Shamimi will continue with wound cleansing, dressing, and closure. Next. Okay, so what is wound cleansing? Wound cleansing is a process of removing inflammatory contaminants from the wound surface. So what are the types of contaminants that need to be removed? Are necrotic tissue, excess exudates, foreign body or foreign objects, and infected tissue. So the solutions that can be used for wound cleansing, we have non-antiseptic and also antiseptic solutions. Next, we are going to look at the non-antiseptic solutions first. So we have normal saline and water for irrigation. So normal saline is a preferred cleanser, but it has no surfactant. But it is physiologic, which is it is isotonic and safe to be used, but it is less effective in dirty and necrotic wound. So for normal saline, once we open it, it should be used within 24 hours because beyond 24 hours, there will be bacterial growth in the solution. For water for irrigation, it is less physiologic, which is it is hypotonic, so it can cause cellular edema, but it is still safe to be used, and it also has no surfactant like normal saline. Next. So these antiseptic solutions, we have chlorhexidine gluconate in aqueous solution. So it is a surfactant, which is effective against gram-positive bacteria, fungi, and also envelope virus. But it is less effective against the gram-negative. But it has a bactericidal and a bacteriostatic action. The next one, we have a superoxidized solution, which is also being used as we use it reduce dermacine. Okay, so it is bactericidal, virucidal, fungicidal, and sporicidal. So it blocks the inflammatory process and may help in biofilm removal, biofilm of the from the wound itself. Okay, so two components in this solution are oxidized water and chlorine. So the oxidized water will be broken down into oxygen and ozone, and other oxidized species. We can help in the wound healing. Next. Okay, the next antiseptic solution is a PHMB or the polyhexamethylene biguanide solution. It helps to soften and remove the slough tissue, and also a biofilm formation can be reduced. It is less painful but a bit costly compared to other antiseptic solutions. So other antiseptic solution other than these three is povidone, hydrogen peroxide, sodium hypochlorite, acetic acid, and usol. So these other types of solution can be used for short-term use because it is painful to the patient and also have the cytotoxic characteristic. Next. Okay, we move on to wound dressing. So, we dress the wound, and the purpose is to protect the wound from any trauma or microbial contamination, and to help reduce the pain, to maintain temperature and moisture the wound, and absorb drainage and debride wound, as well as to control and prevent further bleeding. So an ideal dressing is we remove the excess exudate. It is waterproof and can maintain the moist wound healing environment for trauma protection, and if it allows gases exchange, if appropriate, non-adherent, provide barrier to the pathogen, safe and easy to use, and it provide thermal insulation to the wound. Next. Okay, so types of wound dressing, we have conventional wound dressing and as well as modern dressing. Next, we are going to look first at the conventional dressing. We have gauze as well as gamgee. So as you can see, gauze. So it's soaked with normal saline and antiseptic, and then we dress the wound. And Gamgee is used as a secondary dressing after the primary dressing. Next. So the first modern dressing we have is film, or also known as, we commonly known in the word as the garden lah. Okay, so the purpose is to protect against contamination and friction, maintain moist surface, prevent evaporation, and facilitate assessment of the wound itself. So the advantage of this using film is that it is adherent, it is transparent, so we can inspect the wound without opening the dressing. It is bacterial barrier, waterproof, and breathable. But the disadvantage is that if there's a fluid collection, then possibility of stripping away the newly formed epithelium upon removal, because the edge is a bit sticky. And then the practical usage of this film is for about 2 to 5 days. Next. Okay, next we have hydrogel. So hydrogel is to rehydrate, debride, and dissolve wound. It also can promote moist healing as well as cavity filling. So it is comfortable to the patient, providing more moist environment and reduce pain. It also rehydrate the scar, dissolving agent, as well as promotes granulation. But it needs secondary dressing, as well as maceration of the skin around the wound may happen by the use of hydrogel. So the practical usage is about 2 to 3 days with hydrogel. Next, we have a hydrocolloid. So it provides moist environment, absorb exudate as well as a bacterial barrier. It can cleanse and debride by autolysis, easy to use, cost effective, and it promotes granulation tissue. It is good for low to moderate exuding wounds and waterproof, but then it has an unpleasant odor. It forms a yellow liquid gel upon the touch with the wound, and it is difficult to use in cavities. It can also has the possibility of maceration of the skin around the wound. So the practical usage depends from 2 to 5 days. Next. Next is a calcium alginate. So the purpose is to absorb wound exudates as well as to maintain the moisture around the wound. And the advantage is it is economical, easy to apply, biodegradable, it has hemostatic properties, available in sheet or rope form. It is also effective to stop hemorrhage, but it is not helpful. We don't use it in dry wounds, and it needs secondary dressing as well. And practical use is about 2 to 5 days. Next, okay, the next one is foams. So the purpose of foams is as a cushioning as well as absorbent, and it conforms to body contour, designed for cavity wounds and highly absorbent, and also it provides protection, bacterial and waterproof. But then it can adhere to wound if the exudate dries out. So the practical use, we use it about around 2 to 3 days, depending on the exudates of the wound. Next. Okay, I think I can pass to the next presenter. Thank you.
Okay, Assalamualaikum. My name is Shamimi. So I'm going to continue about the wound dressing. So the next thing is hydrofiber. So basically, it is used for moisture management for moderate to high exudate wound. So it can feel the irregular shape of the wound, such as if there is any cavities, and also prevents any peripheral wound maceration. So what the good things about hydrofiber is that it has a longer wear time, and it is comfortable to, and also non-traumatic upon removal, because the hydrofiber, when you put it, it will become gel-like layer which can easily be removed. And then it can also use to on the infected wound. So the disadvantages is that it's not really helpful for the dry wound, and it needs secondary dressing. So basically, secondary dressing is the dressing we use to cover the primary dressing that we use here. So it practically used for 2 to 5 days. So next one is charcoal, where, as we know, charcoal can absorb any usually any smelly odor. So it is used for odor absorber, and it can reduce any bad odor coming from the wound. So it need to be changed every 2 days because because of the odor itself. So and also it needs secondary dressing for the disadvantages. The next one. So for silver dressing, it is usually used to treat the infected wounds, where it is locally acting dressing, where it knows for bactericidal and also have a broad spectrum antimicrobial. So it is good because there is a no known resistance towards this dressing. However, for the disadvantages, because it is a silver, so there may be discoloration of the wound bed itself. So you need to clean before properly inspecting the wound again. So for practical use of silver dressing, you need to change it every 2 to 3 days, and make sure when you apply the silver dressing, the silver side is facing downward, which is facing the wound bed itself. So it need to be activated with water, and but not normal saline, because normal saline will deactivate the silver dressing purpose. Okay, next one is a multifunctional dressing, or we call it a polymeric membrane, or we call it as polymem. It is used to manage moisture imbalance from dry to moderate. Hydrofiber is from moderate to very high moisture. So for polymem is for dry to moderate wound. The advantages is that it is, has antiseptic property and also offloading property, and the surfactant actually helps to clean the wound. So the disadvantages is that it cannot be used or it is not suitable for heavy oxidate, and can change. It need to be changed for every 2 to 5 days. Next one is composite dressing, or actually composite dressing is a combination of 2 or more dressing materials. So because there is more than one, so the purpose can be varies depend on the type of wound or the purpose that we want to achieve. And the advantage is multifunctioning because we use more than one, and the practical usage is that we need to change it every 2 to 5 days. And the last one is other advanced dressing such as collagen, matrix, and regenerative dressing, culture epidermis, surfactants, and also stem cells. So it is actually not widely used, but some practitioners may use it in a specialized center. So next one. Okay, so next one we move on to the wound closure, where it is very important because after we clean or we debride the wound, we need to close it for this purpose. So the first one is for optimal environment. As we want to promote the wound healing itself, we need to make sure that the wound is closed so that it can have a well vascularized and also stable wound bed. And why we want to close the wound is also for safety. For some may preserve the limb and also affect the site, and some very severe wound can actually save a life if we do a proper closure of the wound. And of course, we want to close the wound because of the aesthetic purposes, because this can restore back the form, and also we can have an optimal and or the best outcome that we want for the patient. And the last one is because we want to preserve the functionality so that the patient can use the affected site or maybe the limb after we properly do the wound closure. Okay, next one is the principles of wound closure. The first, as been mentioned, we need to assess the general and also local wound assessment, like have been mentioned by the presenters before. And then we need to analyze the location, size, and also component involved of the wound. Either there is near to any vital organ, or how deep the wound is. And wound closure is a multidisciplinary action where you also not only you need to treat the wound, but also need to treat the underlying cause or the problems, such as if the patient has diabetes, so you need to optimize the condition of the patient, and make sure that when you do the wound closure, by when you replace or when you want to do a tissue replacement, make sure that it is alike with like, where the appropriate tissue mesh is if possible, it need to be done. And the last one, make sure that you choose the appropriate technique to ensure the safety and also to preserve the function and for the aesthetic purposes. Okay. For there are actually many types of wound, but these are for the wound closure purpose. So there is there are simple wound, complex wound, and also unstable wound. So as the name mentioned, simple wound is readily managed by local wound care. You can either do a primary closure or you subsequent contraction by secondary intention healing. You can do SSG, and also you can do tissue. You can do flap. But for complex, basically, as you can see in the picture, there is a very excessive depth or very excessive size of the wound itself, or the wound is actually located in an unfavorable location. Like in this patient, in the picture is the polar site where it is very big, and it can affect the quality of life of the patient, and also even the life of the patient itself. So usually for complex wound, we use either a distal pedicle tissue flap, or we do microsurgery tissue flap or free flap. And the last one is unstable wound, where it is a recurrence after a simple or complex wound closure. So basically, in the picture, you can see that this patient have like not exudate, like the wound bed is actually not very healthy. You can see a yellowish discoloration where this where this patient has osteomyelitis. So this is unstable wound where you need to do wound debridement, and then you need to properly assess the vascularity, the wound bed, and also the adjacent organ, and then you can decide for the wound closure. Okay, next one. Yeah, these are the algorithm or the of the wound closure principles. So after you assess and also analyze the wound, you can decide either it is unstable wound or a stable wound. So if it is unstable, so you need to do either local management. You need to do both local management and also systemic management, where you need to give antibiotics and treat the underlying disease. Also give good nutrition to the patient so that it can helps in wound healing, and also to revascularize the site. If the wound is a stable wound, it's a simple wound or a stable complex wound, so you can treat it either using a surgical closure, or you do conservative wound correction. So these are based on based on the reconstructive ladder, where you can do a primary closure for a simple wound, and if the patient need skin graft or flap, you can reassess the patient. The difference between I will present about the difference between the graft and also skin flap after this. Okay, next one. Okay, so flap versus graft. So basically, difference between flap is and graft. The flap has its own vascular autonomy, or has its own blood supply, compared to graft, where we skin graft, we does not have its own blood supply, such as skin, bone, nerve, or vein. So the graft actually entirely depends on the blood supply from the recipient side, or from the side that we want to put the graft on. So we need to make sure that the wound bed or the wound that we need to close has a good vascularity, so that it can helps in a successful graft, skin graft. So the function of flaps basically to cover significant contact defect, which to cover the exposing of vital structures as compared to graft, where usually we use graft when there is no exposed vital organs, such as in burn injury wounds or degloving injury wounds. The next. So these are the types of flap and also graft. In flap, we have a local regional flap and also free flap. So the difference between these two is that local regional flap basically does not need for us to cut the blood vessels from the side and reattach it back. But for free flap, we need usually it is from a different side of the body, or different recipient, where we need to cut the blood supply first and then reconnect it back at the wound. For the graft, you have a split skin graft and also full thickness skin graft. These are the most common one, where the split skin graft, as you can see in the picture, I use 100%. Split skin graft, I use 100% of the epidermis and also some of the dermis. However, for FTG, full thickness skin graft, it use 100% of the epidermis and also the dermis itself. Okay, so that's all from us. Is there any question?
Okay, any question to the presenters? That was quite good. No questions? Okay. I think that's it then.
All right, Mister. I think we can end our session. Mister speaking Farah and
Okay.
Sarawat.
All right.
Thank you,
Okay.
Mister.
Thank you.
Thank
Thank you,
you.
Miss.
Thank
Assalamualaikum.
you, everyone.
Bye.